Hi, my name is Amy Vandenbroek, and I'm the Executive Director of the National POLST Paradigm. This is a re-recording of the presentation I gave to the Slow Medicine Facebook group. We had to re-record it due to audio issues, but questions and answers from that presentation are included at the end of this presentation. This is a 30-minute presentation. Thank you for taking the time today to learn about the POLST paradigm and how it fits into advanced care planning. Starting with the basics, POLST stands for Physician Orders for Life-Sustaining Treatment. Your state may call it something different. Not all states use the term POLST, and these other terms are used instead. There's about 13 total, but they are all part of the POLST paradigm. The fundamentals of these programs are the same, but states have created little tweaks based on the values, culture, and society within each state. I'm going to use the term POLST in this presentation, but what I say applies to all POLST paradigm programs. The POLST paradigm is a process that includes a brightly colored portable medical order. Most states use some shade of pink. The POLST form is a portable medical order designed to support patients transitioning between facilities or who live outside of a facility by communicating what their treatment wishes are. In the event of a medical emergency, when time is critical for medical decision-making, this POLST form serves as an immediately available and recognizable order set in a standardized format to aid emergency personnel so that they can provide the patient the treatments that the patient wanted during that medical emergency. The form is completed based on what the patient wanted and what they told their healthcare professional that they wanted after a shared decision-making conversation. POLST is not just for physicians. This is a team effort to have a conversation, and in most states, physician assistants and advanced practice registered nurses are able to sign a POLST form. You can find the full chart of who can sign at polst.org/map. POLST exists because of people like Max, and you can find his story on our website. Max's story shows why an advance directive isn't always enough. Max had clearly communicated his decisions about not wanting CPR after being diagnosed with a progressive heart condition, but he put this information in an advance directive. Although he gave copies to everyone in his family, when he collapsed as a result of his heart condition, emergency personnel were unable to honor his wish not to receive CPR because that wish was not documented in a medical order. It was only in an advance directive, which is a legal document. Max's death would have been very different if the responding emergency personnel had had a POLST form or medical order to direct the course of his treatment. It was hearing stories like Max's that in 1991, leading medical ethicists in Oregon recognized that advance directives were inadequate for patients with serious illness or frailty like Max, who frequently required emergency medical care or had an idea of what emergency medical crisis they would be facing. They realized that patient preferences for end-of-life care were not consistently honored, so a group of stakeholders developed a new tool for honoring patients' wishes for end-of-life treatment. After several years of evaluation, the program became known as POLST. All states have some level of POLST development, including Guam, a U.S. territory that is just getting started. This map shows where development is occurring. The states labeled as mature or endorsed, which are the two darker color pinks, have shown that they have implemented programs and forms that meet the national standards. The lighter color pink are developing programs, and these are programs that are working to implement the program. Most are actively working towards becoming endorsed. And again, endorsed does not mean that it's statewide. It just means that the program and form meet national standards. We have a couple of gray states where the program does not conform to national standards and is not being changed to adopt that. You can find more information about those states by clicking on them online at our website, polst.org/map. This map, however, gives a better sense of where POLST is actually being used. The mature states, which are Oregon, California, and West Virginia, have all proven through research that POLST is widely used within those states. All other states The data comes from the POLST Coalition or Task Force leadership, so if you have a question, you can let me know or find your leader, again, at polst.org/map. So the darker green states are where you should be able to find it statewide, whereas the lightest color green or white are places where it's going to be a little bit more challenging to find POLST, or you might not even find people that know what it is. And that's where the state leaders can become helpful if you are interested in learning more. I want to start with the fundamentals of the POLST paradigm. And to begin, let's start with what advanced care planning is. There are three categories of advanced care planning: standard of care, advanced directives, and medical orders. With the standard of care, emergency personnel are required to do everything possible to attempt to save someone's life during a medical emergency unless there is a medical order to the contrary. So if you do nothing, this is what you will get. Emergency personnel will do everything possible to attempt to save your life, and then at the hospital, they will look at state law to determine who can speak for you. In some states, there is no law, so hospital policy will determine who ultimately is involved in helping making your care decision. The next one are advanced directives. These are called different things in different states, but they are legal documents that are used to provide both your general treatment wishes for some unknown future medical crisis and also used to identify a surrogate, or the person who can speak on your behalf when you become incapacitated or unable to speak for yourself. Again, during an emergency, emergency personnel will attempt everything possible to save your life. But once you get to the hospital will look at your advanced directive to determine who your surrogate is, to include them in the health plan decision making, and then to look at your general treatment wishes. I have some slides later on in this presentation that will emphasize this point. And then last, we have medical orders. These are do not resuscitate orders and POLST forms. During an emergency, because they are medical orders, emergency personnel can follow the orders on a POLST form. Again, once you go to the hospital, if you go to the hospital will look at your advanced directive to determine who your surrogate is, but they will be following the orders on your POLST form. The most fundamental difference for patients between advanced directives and POLST forms is that emergency personnel are able to follow POLST form at the point of emergency, and this will make a difference as we'll discuss throughout the presentation. Otherwise, there are other differences listed on this, and you can also find additional information on our website at polst.org. At the end of the day, advanced directives and POLST forms work together to help ensure patient treatment wishes are known and honored. Every adult should have an advanced directive. Having a surrogate identified is critical because surrogates have the ability in most states to change a POLST form if necessary. But it is only later when a POLST form should be considered, again, when somebody is seriously ill or frail. The question, would I be surprised if this patient died within the next year, is the framework that was developed in the early 1990s and has been shown to be effective for helping clinicians predict which patients with cancer were nearing the end of life. And this is the language that we use for determining if POLST is appropriate for a patient. POLST forms are intended to be used by those who are seriously ill or frail towards the end of life. In other words, those individuals who are at the greatest risk of having a medical emergency and who may not want our standard of care. There is no need for diagnosis of being terminal. That's not anything healthcare professionals want to do or that patients want to hear. But you want to think instead, would I be surprised if this patient died within the next year? So again, no need to prognosticate that the patient will die or think that the patient will die. It's just, would I be surprised? And we've seen from, for example, the Oregon POLST Registry, that there are patients who have had POLST forms for many years, but every single year you can answer this question with a yes. And at the end of the day, this is because POLST forms are orders for what the patient would want tonight. Healthy individuals would want full treatment. There isn't a question on this. Instead, it is only when a patient has a diagnosis and a prognosis and can have a thoughtful conversation about what the various treatment options available to them mean. So what would ICU or intensive care unit treatment mean for that specific patient with that specific medical condition? Or what would it mean for that patient to be on the breathing machine? To be able to have that specific conversation is critical to completing a POLST form. Some common questions that we get about POLST forms are about who is appropriate. So I want to be clear that just because somebody reaches a certain age or enters a certain facility does not mean that they are appropriate. Many 65-year-olds are too healthy for a POLST form, but again, should be encouraged to complete an advance directive if they don't already have one. Similarly, just because a patient enters a facility, such as a nursing home, also doesn't mean that they're appropriate for a POLST form. POLST can be used in pediatric populations, except in Colorado. And for patients with significant disabilities, healthcare professionals need to be very thoughtful about whether the patient is truly appropriate for a POLST form. There's guidance on our website, and here are some questions that you can ask. We want to be mindful that POLST, again, should only be used when a person is seriously ill or frail, and healthcare professionals would not be surprised if they died within a year. But let's look at the POLST form itself. In most forms, Section A functions as a do not resuscitate order, but goes further. Whereas a do not resuscitate order, or DNR, only provides evidence that the patient did not want to be resuscitated, a POLST form allows a patient to confirm they actually did want CPR or to be resuscitated. And further, and this is important, DNRs tell a very limited story about patient treatment wishes. If a patient is responsive, if they have a pulse, or if they are breathing, then this section is useless in an emergency situation because the question is no longer whether the patient wanted CPR or did not want CPR. The question is what treatment the patient wanted during this medical emergency. A review of POLST forms from the first year of the Oregon POLST Registry shows that there is a 50% chance that a patient who said do not resuscitate also wants to go to the hospital. The other 50% want to stay where they are and receive comfort measures only. So if a patient is just using a DNR, EMS would still bring those in a medical emergency but not requiring resuscitation to the hospital, which is something half of these patients do not want. So when a patient is still in medical crisis but does not need resuscitation, the real value of POLST comes into play. And the heart of a POLST form is in its Section B, which offers 3 levels of treatments. The first is full treatment. The patient wants our standard of care, which is everything possible, including being in the intensive care unit, or ICU, and on a breathing machine. Limited or selective treatment is when the patient wants to go to the hospital if necessary, but prefers to avoid the ICU and does not want to be on a breathing machine. And then the third option is comfort measures only. The patient wants to stay where they are and have their symptoms treated. Again, the form is just the most visible part of the POLST paradigm, but the fundamental part of the process is really the conversation. Conversation is the cornerstone of the POLST paradigm, and the form itself is only as good as the conversation preceding it. The POLST form is a step in a process that depends on a conversation, and it's designed to document treatment decisions made after shared decision-making conversations between a patient and his or her healthcare professional. The discussion should include the patient's diagnosis, prognosis, treatment options, including the risks and benefits of each option, and what the patient considers an acceptable quality of life. What do they value? What do they want to be doing? And then using all that information, the healthcare professional and the patient should work together to make decisions about what treatments the patient wants to have during a medical emergency. And the result may be the completion of a POLST form, but it may also just be a simple care planning discussion documented in the patient's medical record. If a POLST is completed, then the healthcare professional, and in most states, the patients both need to sign the POLST form. The form should always be completed by the healthcare professional. The original is then given to the patient, and then the healthcare professional should put a copy in the patient's medical record. And in states where it exists, the healthcare professional should send a copy to the registry. You can find which states have a registry on our website at polst.org/map. POLST forms are not one-and-done documents. We recognize that things change over time, including a patient's prognosis, health status, and what they find appropriate in terms of their quality of life or their goals or what they want to accomplish. Treatment options can change, and preferences for treatments may change. So the form is intended to be dynamic, reflecting the patient's current wishes about the medical treatments he or she wants to receive. And this dynamic process is achieved through ongoing conversations when a POLST form review is completed, which should be during appointments with healthcare professionals, during changes in level of care, changes of location of care, especially upon admission and discharge, and then whenever the patient has a change in what they feel as a goal of care, treatment preference, or what constitutes an acceptable quality of life. Again, emphasizing the dynamic nature of the POLST form. A patient may start wanting full treatment, which is really our standard of care. So for patients who are seriously ill or frail, they may use a POLST form to emphasize that this is in fact the treatment level that they want to receive. And this can help alleviate surrogate burden or any confusion among family members or clinicians about what the patient may have wanted. However, since prognosis, quality of life, and the patient goals of care may change, all forms, again, are easily modified. So while a patient may start with full treatment, if their prognosis worsens or the quality of life is horrible and not likely to change, they may wish to choose limited treatment. If things get better, for example, a clinical trial offers some hope, they may wish to change back to full treatment. On the other hand, if their prognosis worsens, a patient may choose to have comfort measures only. A patient's wishes for these treatment orders can change over time. About 15% of POLST forms each month in Oregon are revisions. So we know POLST forms are being changed. And of course, a patient may choose to void their form at any time. With these next couple of slides, I want to emphasize how POLST medical orders bring advanced care planning upstream during an emergency as compared to our current standard of care or using traditional advance directives. So the patient has an emergency and EMS is called. Everything is done in an attempt to save the life, and the patient ends up at the hospital in the intensive care unit. Then the healthcare team, once the patient is stabilized, will look at the advance directive if one exists and can be found, and they can see who the surrogate is. Together, the surrogate and healthcare professionals will look at the general treatment wishes provided in that advance directive to inform the plan of care about whether the patient remains in the ICU or receives a different level of treatment. With POLST, however, things change. The patient has an emergency and EMS is called. But EMS reviews the POLST form, and EMS is trained to look for a brightly colored document, again, most states is pink, on a refrigerator, in a refrigerator, or in a medicine cabinet. It varies a little bit by state. But they find the POLST form and they review it. If it says comfort measures only, that means the patient didn't want to go to the hospital and wanted to be treated where they are. So EMS will do that. And there won't be a trip to the hospital unless comfort cannot be managed where the patient is. If the patient does need to go to the hospital, staff there will be able to see that the patient's goal is to be able to get back to where they were, and that can inform the care plan. If the patient did not have comfort measures only checked, then said they will be transported to the hospital, but again, there's information. If the patient had said they wanted limited treatment only, then they will go to the hospital but not be put into the intensive care unit. And again, if they wanted full treatment, then they will get everything that they need. Well, everyone will get everything they need, but for full treatment, the patient has made it clear that they're comfortable being in the intensive care unit and having a breathing machine. So some key things to reiterate. First, completing the POLST form is always voluntary. Just as it's not required to complete an advance directive or even get health care, patients should never be required to complete a POLST form, even as a condition of admission to a facility. 2, POLST forms can be changed or revoked at any time. POLST forms are about treatment wishes. Comfort measures are always provided. but treatments aren't. Instead, we want to give and honor patient autonomy about what treatments they wanted to receive. And finally, POLST forms are signed by healthcare professionals after a conversation. These forms are medical orders, so healthcare professionals must sign them in order for them to be valid. And almost all forms have an attestation or statement that the healthcare professional is agreeing that the orders on the form reflect the patient treatment wishes, and those wishes cannot be known unless a conversation has taken place. And again, who can sign varies by state, and you can find information online. So for those of you who like data and numbers, the next couple of slides are for you. In 2014, the Journal of the American Geriatric Society published a study showing the strong connection between POLST form orders and where people ultimately die. This article demonstrates that POLST form orders are honored, and this chart shows the results of reviewing 18,000 death records of individuals with valid POLST forms in the Oregon POLST Registry who died of natural causes in Oregon between 2010 and 2011. Researchers compared those individual treatment wishes with their location of death. Without a POLST form in the registry, individuals had a 34% chance of dying in the hospital. The other three bars demonstrate the value of POLST compared to that baseline. When orders are marked for comfort measures only, it means the patient didn't want to go to the hospital, and only 6.4% of patients with a POLST form ordering comfort measures only ended up dying in the hospital. Likewise, if the patient wanted full treatment, they were 30% more likely to end up dying in the hospital than those in the baseline. Essentially, you get what you want. No other tool has shown this level of effectiveness, and this data is compelling to states wanting to develop a robust POLST program or to implement individuals wanting to implement within their facility. The national POLST paradigm has a vision that someone can get a POLST in one state and be able to travel anywhere in the United States, knowing that their form can be honored wherever they are during a medical emergency. This is only possible if all states adopt the same standards and form or have forms that are similar enough. The structure we have supports this. We provide help with developing and implementation at the state level, while each state builds its own coalition to implement the POLST paradigm and develop their own program through a grassroots approach or through legislation or regulation. Approaches do vary. They're encouraged to work and participate in the national POLST paradigm and to adopt the national standards for their program and for their form. The national POLST paradigm is the name of our organization and represents the ideals of any POLST paradigm program. We work like a collective impact where all participants have a shared vision for change and work to build consensus on strategies. We're really the backbone of the initiative, and we coordinate guidance, research, education, policy, and quality assurance for all POLST programs to follow, and we encourage all states, territories, and Washington, D.C. to participate in the national organization. No state will be successful on its own. This is a national movement, and we need to be very much in sync with one another for it to be successful and achieve our vision. Otherwise, there are no federal rules or regulations that explicitly mention POLST. This means that states participating in the national POLST paradigm help shape the standards, requirements, and appropriate use. We build on consensus, and again, the more consistent we can be in implementation, the greater the integrity of the overall paradigm. Thank you. The questions that I had received during the initial presentation. First, from Suzanne from Vermont, she asked in what way the Vermont program doesn't comply and why it was listed as nonconforming. The gray states on our map, Vermont, Massachusetts, Maryland, and Nebraska, generally have forms that do not match the national standards. And for these states, the problem is, or the issues and concerns that we have are twofold. First, POLST is a paper form. And when you have forms that break apart that section B, again, those were the three treatment options of full treatment, limited or selective treatment, or comfort measures only, into multiple questions, you increase the chances of having a conflicting order set. And we want to make sure that the form is always very clear about what treatments the patient wanted and to make sure that there's no confusion with emergency personnel about that. Research, as I presented, has shown that the three levels of treatment options are effective, and we encourage most states to follow that. The second reason these are a concern is reciprocity. Again, our national vision is that a patient would be able to have a form in one state and have it be honored in any other state. The states that have legislation, some of them talk about whether or not they can accept a form from another state, and the language is typically something like the form needs to be substantially similar to their state form. So when we have all states meeting the same requirements of what a form looks like, we increase the chances that it complies with state law and that patients are able to have their form honored wherever they travel. So any state that has a form, that whatever they call it, but something looking like a POLST form that does not have the typical Section A, and that, more importantly, that typical Section B of the 3 treatment options, and they are not interested in changing, those are states that we are going to identify as non-conforming to make it clear that they do not meet the national standards and that we do not approve of how those forms are being implemented. We had a little bit of discussion about advanced directives and how critical they still are within advanced care planning. For POLST forms, advanced directives are helpful because, again, surrogates are able to help complete POLST forms in most states. A couple of states have some restrictions that if a patient fills out a POLST form with DNR, a surrogate cannot change it to be CPR, but otherwise a surrogate is able to update, modify, or even void a POLST form for a patient. So having a legally authorized surrogate is critical, and that is done through advanced directives. There was a question about what the focus is of the national POLST paradigm. What are our main efforts? We have 2 main efforts right now. The first is focusing on creating a single national POLST form. Again, the hope is to eliminate any question about reciprocity or whether or not the form in one state is valid in another. I am working with leaders from all states and Washington, D.C. to build on consensus a single national form that hopefully all states in time can sign on to. Some states will have to make legislative or regulatory changes, but having a single form, again, eliminates reciprocity. It increases our ability to educate and to share education resources. It can help from a health policy standpoint, and it can help with a quality assurance standpoint. So we're hopeful that that can move forward. And then the second piece is technology. POLST is a paper form, but there is a lot of interest in technology because it can save administrative time, it can eliminate improper order sets, and when it's integrated with an electronic medical record, it has the potential of reminding healthcare professionals of what the patient wanted and when they're putting order sets in that don't match. We have a technology consensus conference coming up in October, and the hope of this is to create a white paper that will help states and facilities integrate POLST forms within electronic medical records and health information exchanges, and to consider what is needed to build a registry. All of these are with the intent of, again, decreasing administrative burden, but also helping make sure that the POLST form is able to be found during an emergency when it's critical. And then the last discussion that we had was a question about using POLST within a population of healthy patients, people who really just don't want to go to the hospital and wanting to use a POLST form. The main thoughts on this were both ethical and then medical. POLST, again, is a medical order, and any healthcare professional who's licensed and authorized to complete the form needs to think about whether it's medically appropriate to provide this medical order for that particular patient. If it's inappropriate use, it can be a licensure issue. The National POLST Paradigm has said POLST is intended for patients who are seriously ill or frail, whose healthcare professionals wouldn't be surprised if the patient died within a year. We do not enforce that, but that is the language we encourage all states to use. There are states who have passed legislation that limits the population, so it may also be an issue if you use it, if you're a healthcare professional using POLST in a healthy person, that you're violating state law. And then ethically, just thinking about whether or not it's appropriate to complete that form in that way for that patient. For healthy patients, again, POLST forms should be full treatment, hence requesting CPR, which is our standard of care. So there's really no need for a POLST form. And in fact, it can set up a situation where there can be a surrogate burden. If the patient ends up getting sick, then you've got a POLST form out there saying that the patient wanted these things, but you don't know necessarily the conversation behind it because there was really no medical condition and no specificity about what all of those things would mean, especially in light of new information. So we encourage everyone to look at state law, but to follow the national guidelines and use POLST only within the populations where you can have a very specific conversation of what the patient's medical condition is today, what their prognosis is for tomorrow, what likely medical emergencies they may face, and then what the treatment options mean for within that context, and then how it plays into their goals of care. And only when you can have a conversation with that level of specificity should a POLST form be completed. If you have any other questions, please feel free to contact us at POLST.org. Contact us is in the upper right corner, and we look forward to hearing from you. Thank you again for your time today. Take care.